Welcome, my friends, to the Bob and Brad podcast, produced by Bob and Brad, the two most famous physical therapists on the internet. I am Bob, and I'm exactly one half of the Bob and Brad team. The better half, if you ask me. Today, we have a real special guest. He is a board-certified neurosurgeon. Yes. And he's with Inspired Spine is the best way to get a hold of him. InspiredSpine.com. And he does a new procedure fairly new, and he's done a lot of these as a very non-invasive surgery. So he holds both an MD and a PhD, and he was one of the first 30 surgeons in the United States to perform this groundbreaking surgery. So we'll be talking about all of that. We'll be talking about what patients would benefit from this and whether or not you would qualify for this type of surgery. Dr. Abbasi, thank you so much for coming on our program today.
My pleasure.
We got a lot of subjects to talk about today, a lot of things to go over. So I thought we'd go ahead and get started. Could you first give me a summary of your background? I think what people would love to hear your schooling and a little bit of your experience.
Well, I'm trained as a physician in 3 continents, including in Iran, where I'm born, but as well, I did my med school and a dissertation, a PhD in computer science in Germany. And then I moved to California. I did the research for spine surgery and use of computers in the spine surgery in Stanford, California. Then I went to Dartmouth College. I did a 1 year of internship in general surgery. Then I applied and I started a neurosurgery residency in Galveston, Texas, in University of Texas Medical Branch, and practically rotated in all the major hospitals in Houston. Before I started my clinical practice in South Dakota, and I have been practicing in Minnesota almost for 10 years.
Gotcha.
And practically I've been concentrating on minimal invasive treatment of the spine and spinal pathologies.
Very good. We'll get into that. We'll get into the weeds real quickly on that too. But right now, what is Inspired Spine? I should mention, by the way, if people want to get a hold of you as far as for surgery or anything else, the best site would be to go to is www.inspiredspine.com, correct?
Correct.
Okay. And we'll talk about where you're located and stuff, but what is Inspired Spine?
Well, Inspired Spine came to existence because the way I was trained to do spine surgery. And I'm going to use an analogy that everybody I hope would understand. Imagine you want to take Osama bin Laden out and you nuke entire city.
Gotcha.
Versus you send the SEAL Team 6 to take one person or few people out. But for lack of other terms, the way we still do spine surgeries, we fillet your back. We cause so much damage. We nuke the whole city to get the bad culprit, the bad agent out. And I was inspired by the actual event when about 10 years ago, somebody told me that one of the surgeries that I do for the spine can be done under 1 hour. And that was unbelievable for me because I was a very good surgeon, at least I thought at that point, and you would need 3 hours for that surgery. And in that 3 hours, what we do, we cut, we cause bleeding. We literally cook the tissue to stop the bleeding, create lots of dead tissue. We cause a lot of damage to get where we need to go. And somebody told me that all of that can be done without the cooking and damaging the tissue.
Gotcha.
For 1 hour. I think I didn't believe it at that time, but my blessing was I didn't stop there. I didn't say, I don't believe it, leave me alone. I said, I don't believe it, I want to see it. So I flew to Georgia, Atlanta, Georgia, and I saw not only that surgery was done under an hour, but I saw that patient walking out of surgery center, a surgery that my patient would stay days in the hospital. I saw that patient walking out of that place in literally 3 hours. And that was truly inspiring for me, that it opened my eyes. For lack of other term, my jaw fell on the floor and I saw that my world has to change. But I noticed as well that process is not an easy process. I saw somebody flying a space shuttle, and I knew with proper training I can do that, but I knew as well lots of things has to change so more people can do that. So
gotcha.
Hence Inspired Spine, the process, the accumulation of the team that start the project to make this new way of doing surgery on the spine without massacring the spine and making it approachable for more surgeons so more patient can benefit from it.
So we're basically talking about a traditional surgery, a fusion, where you're fusing the spine, where you got to go in and you got to cut a lot of muscles, which have trouble recovering, correct?
In an open old-fashioned surgery, we make a midline incision. We for people who have done hunting or fishing, they know what I mean.
Sure.
Exactly, that's what we do. We fillet the patient open. We kill all those muscles. On top of that, every time you cut in a living tissue, it's going to bleed. What we use, we call that bipolar or BOVI. These are fancy terms to say that we use electricity to literally, not figuratively, cook the tissue to stop the bleeding. Well, imagine we don't have to do all of that now.
Exactly. I'll give a personal example. I just had some cysts removed from my mouth, and I have numbness and I have scar tissue. So if I slur my words, you're going to know why. So we mentioned your website. What type of services do you provide besides the surgery? Are there other services you provide?
Yes. Spine surgery, first of all, we need to know a little stat about the spine surgery. Spine surgery is not a rare condition that people need. Spine is number 2 reason for disability in the United States, only second to cardiovascular disease.
Wow.
About 1 million spine surgeries are performed in the United States. That was the statistic from Center for Medicare in 2015. Now there are probably even more. So this is a common condition. It's almost hard not to know somebody with spine condition if you are my age or your age. As a matter of fact, by the time you're 50 years old, there is only 30% chance you don't have spine problem. By the time you're 70 years old, there is a 98% chance that you do have spine problem. There's only 1 to 2% chance you don't have spine problem. Now, we are in a lucky situation that we have put tremendous amount of effort in, first of all, avoiding spine problem, and that is actually where ISLAF and KLA come in. We have a tremendous amount of information we provide to our patient how to avoid it. If they cannot avoid spine problem, we have a tremendous amount of protocols that we have put it with the multidisciplinary groups together to treat the patient without the surgery. As a matter of fact, I just saw about 25 patients, and only 2 of them I scheduled for the surgery because the rest of them we are going to try to help them without the surgery. From those people who need a surgery, only a fraction need fusion. Fusion is when you take the disc out and make the bone grow together. Many of those other patients we can help without the fusion. And the way, again, I make my patient understand that our spine is made of interspersing bone and disc. A disc is like a tire of a car that cushion the car against the road, this cushion 2 bones against each other and keep the space open for the nerve. Many times you can patch a car, and that is non-fusion kind of surgery. Many times, though, if the disc is completely destroyed like a slashed open tire, you have to get rid of it. And that is where our procedure really shines, which makes a 5-hour surgery a 1-hour surgery and put the patient on much faster recovery. Again, because we don't cause too much damage to get the job done.
Sure. Unfortunately, I do know someone really well who had spinal surgery. My mother had 2 of them, unfortunately, and I wish she would have known about you because she went through the traditional manner. She's 91 years old. So
when did she get the surgery, if I may ask?
She had one done when she was, I think she was in her early 80s, I think.
Okay.
And the other one was done maybe 4 years before.
4 years before.
And it was like, as you know, the as one level fails, then you put the surgery there, and then the next level fails, and that's what happened to her. So
part of that as well is, I understand you are a physical therapist. You know the
Correct.
Human anatomy well.
Correct.
You know those muscles in the spine, they are multisegmental, meaning that even if you do surgery, let's say for one level, many muscles go many levels up and down.
Right.
And I'm going to tell you the dirty secret of spine surgeon. And that is that when we cut those muscles, we don't reattach them.
Really?
Yeah.
Well,
and you can imagine that if you have like shoulder surgery, if you cut the muscle and don't reattach them, you are rendering that shoulder physiologically inert and non-functional. Many times in the spine surgery, we actually cut the muscle, cut the bone that the muscle are attached to, and we just let those muscles just floating.
Sure.
So you can imagine that after the surgery, first of all, those muscles try to contract, but they're not attached to anything. They never stop contracting. People go to spasm. It takes months before they can be even functional. And as well, those muscles always die. They don't recover from that process.
You're right, because I mean, how could they be functional after that if they don't have one side's not attached? Wow!
But don't repeat that secret.
That's going to be that's going to be on our Facebook. You know.
I know. So, I'm kidding.
All right, let's start talking about the procedure. So it's OLLIF. We don't want to confuse it with OLIF.
Right.
I don't know why you guys did that. They should have been way different.
We doctors love acronyms.
Yeah, that's true.
Our days are so busy, we try to make the communication as short and dense as possible.
Yeah.
But let me just give you a little story about that. I think it's very educational. And we have tons of videos online regarding that. And Kayla can send you pictures that you can blend in.
Sure.
And since 1950s, spine surgeons are opening up the back, filling you open, doing surgery from the back. We call that posterior lumbar interbody fusion, or PLIF.
Gotcha.
Since 1980s, we are going a little to the side so we don't have to push on the nerves. We call that process TLIF, or transforaminal lumbar interbody fusion. And those standards from 70 and almost 40 years ago are by numbers are mostly performed surgeries today. Imagine you're driving a car that is 70 and 40 years old.
Right.
This is the standard of the spine surgery today. Well, we have fancier instruments and so on and so forth, but the standards is the same. Now, even then we knew that cutting those muscles is not good for the patient. So what we do, we sometimes open up the belly. By the way, every surgery on the spine you can imagine, I have done. I'm an expert on all kinds of spine surgeries. So it's not, I didn't choose one or another based on how familiar I am with that. But for many years, we are doing opening up your belly, putting the organs to the side, and then go and take the bad disc out. Either way, we get to the disc. And obviously here we have to traverse abdominal or belly organs like your guts, your major vessels.
Sure.
And sometimes that can go the wrong way. As a matter of fact, I just heard that University of Minnesota stopped doing that surgeries going from the front because of some bad results.
Really?
Yeah,
Wow.
and now since 2000, actually as well, there's another way of going to from the side to do the surgery from the side. But that surgery, you cannot do it for bottom two levels very well, as well as ribs sometimes is in your way. It's very awkward surgery, but still a good surgery once it's done.
Do they still go through muscles on that surgery?
On this abdominal muscle, yeah, they still do.
What
They
about
make a
what
decision
about the
about
side one?
as well. You have to go through abdominal muscle.
Oh, you
Obviously,
do.
it's much better. It's much better than going through the muscles in the back.
I
But
gotcha.
still, you have to go through certain muscle. But because of the limitation from going the front, which we call ALIF, ALIF, or
Yeah.
lateral, which we call direct or lateral lumbar interbody fusion, LLIF, we have invented a new method of going still from the front and side. We call that OLLIF ATP, or oblique lateral lumbar interbody anterior to psoas. You still have to go through the belly, patient is on the side, and still in many regards it's awkward because still you have to turn the patient and do surgery from the back because we put screws still in the back from the back. So, but the surgery we do is oblique lateral posterior lumbar interbody fusion, where we go from obliquely, but obliquely from the back, not obliquely from the front. Practically, we don't have to enter the abdominal cavity. We don't have to touch the organ. We don't have to touch any of the vessels. And that's sort of exactly in the border between the back and front, in a very thin line. And practically, when I show anatomical picture, Kayla will provide it to you. It's many my colleagues ask me, how can you operate through that thin line? Well, the answer to that is instruments, technology, and experience.
Gotcha.
By the way, we have refined the technique to a point that any spine surgeon can learn that. And that is truly what we are proud of, that not only we do the surgery, we teach it to everybody who wants to learn that.
Now, you're a neurosurgeon. Can an orthopedic surgeon learn this?
Now, there's two ways to become a spine surgeon. Neurosurgeon, we get exposure from day one of our residency on the spine, whereas orthopedic surgeon, usually they have to do a fellowship to get the exposure to spine surgery. But once we are in practice, we are equally good at that. And so my orthopedic colleagues, after they have been in practice for a few years, they are as good as any spine surgeon in the spine surgery. And there are a few differences though. Orthopedics are more used to work on the bone. They're really good at that.
Right.
We neurosurgeons are very good at doing close to the nerves, and we are just used to work in smaller spaces and so on.
Sure.
My advantage, my privilege, my truly my luck is that we have a multidisciplinary group of orthopedic surgeon and spine surgeon, and we have learned from each other a lot. So we have combined the advantage of both worlds in one service.
Gotcha. So at one point through this new surgery that is less invasive, you go through Kambin's triangle. Did I say that correctly?
Oh, yes, you did. You did.
And
well, if you remember, practically in a situation where when the problem is the disc, we have to get to the discs. And I described to you all the different ways of getting to the disc, except the OLLIF, oblique lateral posterior lumbar interbody fusion. And I'm going to try to see if I can share my screen with you. Here, PLIF going from the back is going in that direction, TLIF going in that direction, ALIF, anterior lumbar interbody fusion, direct lateral or LLIF, they have some funny names for that. This is the OLLIF with one L that we go anterior to psoas, which is this muscle here.
Right. Yeah.
And our surgery is practically this. Do you see that thin line? That is the thin line we use to get to the disc. And the reason we can do that, let me just go back here and show you This is the Kambin triangle.
So
When you look at the side of when you look at the side of the spine, practically this is the side view of your spine.
Yep.
And this is the disc. This is the bone above and below. This is the facet or the joint in the back. And this is the nerve root. Do you see that little triangle there?
I do.
In 1970s, we found out that is the area that you don't have any nerves and you don't have any vessels, no arteries or veins. So it's a safe area to enter the disc. The problem is that is size of my literally index finger's nail.
Gotcha.
Our technology was never good enough to utilize that. And guess what? Now it is. The same way that our technology wasn't good of having a whole computer in palm of my hand, and now it is.
Now it is, yes.
Here we are. We are just there with our technology to utilize that. And that is enable us to literally put a tube inside of that with two C-arms. And these two C-arms practically are my eyes. I can look inside of you like a Superman X-ray vision. Know everything inside of you. And this is not figurative, this is literal.
Sure.
And then I use this very set of smart instrument that I bypass the nerve. I do the surgery through a tube that is a little thicker than this pen.
Gotcha.
And because I don't have to cut the muscle, I just dilate the muscle. When they fall back, they literally fall back, and with virtual no scarring, we can do the surgery. I want to show you a picture here. That might not be something that all your viewers want to see because it's a little gory.
They can fast forward through it.
Yeah, but here you see a patient of mine. In 2012, I did an open old-fashioned surgery.
Sure.
The white tissue, you see there is scar. It is white because this is scar. It's dead tissue, physiologically dead tissue. It has no blood supply. These are not muscles anymore. But on the right side, you see in 2 years later, patient, if you remember talking about your mother, that you do a surgery on one level, then other levels go bad. Then other level did go bad. In 2015, patient had an accident actually in rural Minnesota, as you know. There are a lot of deer wandering around. Yeah. And the patient hit a deer, broke everything, came back to the hospital. I have to open it up all. And you see where I did my minimal invasively. This is a pristine spine. This is pristine muscle. This is live muscle. And that's why this muscle can contribute to patients' the recovery, because I'm not cutting the blood supply of the bone. And that is because I didn't have to cut to get to this spine.
Right.
So
the muscles can continue to function.
Exactly. Even more important than that, not only they've continued to function, you may or may not know that the vascularization of the bone, by the way, I'm going to go up here. This is open versus minimal invasive surgery.
Oh my gosh.
But it's not about what the cuts in the skin, but what happened under the skin that makes the tissue more viable, more alive. Now I'm going to show you another picture that if I explain it to you, I hope you understand that. The blood supply to the bone is through surrounding muscle. And 75% of the blood supply to our bones in the spine is through the muscle in the back. So if I do a traditional surgery, I'm reducing the blood supply to the bone to 25% of its original level. Imagine there is a bridge between St. Paul and Minneapolis, and I'm closing 3 of the lines from 4. You can imagine that has impact on the material to move from one place to another. That is why spine doesn't heal, because too much damage to get in.
If you have an elderly person who maybe has a little osteoporosis already, I imagine this is devastating.
Absolutely it is. And especially they rely with when we get older, our vessels becomes more narrow. And imagine not only you're old and you have a narrow vessel going to the bone, on top of that, you reduce it to 25% of the original level.
Wow.
So this cannot be without consequence.
Right. That's fascinating. That's amazing to me. I just had a lady on who's kind of an expert on osteoporosis. I wonder if she realizes this.
Yeah.
It's crazy.
This picture shows the muscle in the spine. And what I tell to my patient, or actually, I'm a little tricky, and I ask them, which of these muscles do you think we in spine, in open old-fashioned spine surgery, we reattach after we cut it to get in? And the answer to that is practically very little.
So how long has this OLLIF been available as a procedure?
About 10 years. But the OLLIF that it's now we are practicing is not the same OLLIF that was being practiced 10 years ago. And I hope you get a good picture of understanding why. Because the OLLIF that I used to practice, when I learned that, it was a flip phone. Now we have the smartphone version of it.
Makes sense. Makes sense.
It made many of the processes more intuitive, more that the instrument take care of lots of things that the surgeon had to consciously take care of.
Gotcha. Now, you mentioned before that you saw this patient who had the surgery the first time, that they were leaving like a day or so after the surgery. And you want to compare some of the things that you find with the OLLIF and the traditional fusion surgery?
Yes. And first of all, we need to talk about how these surgeries are done. The surgeries are done in the fashion that we approach the disc, we take the bad disc out, and then we stabilize the spine.
Gotcha.
In the traditional surgery, there's lots of work need to get done to just get to the spine. As a matter of fact, average spine surgery in University of Minnesota, even Mayo, is about 4 to 5 hours for one level.
Wow.
Because we don't have to do cutting and so on, our surgery for one level, the surgery that Mayo Clinic needs 4 to 5 hours, we do it under 1 hour.
Wow. Amazing.
Obviously, when you do that much surgery, you cut that, there's lots of blood loss.
Sure.
Blood loss in open surgery, even in University of Minnesota or Mayo or average in the United States, is about somewhere between 500 to 1,000 cc. Our average blood loss for one level fusion is 1/10 to 1/20th of that, about 50 to 100 cc. And obviously, we talked about in open surgery, you cut the tissue, you cook the tissue. Well, it's literally dead meat waiting there to get infected.
Wow.
So average risk of the infection in open surgery is 3 to 8%. Our average risk of infection is 0.17%.
Wow.
Meaning that 1/20th, even in the lowest paper reported, we cut it by 5% of that, meaning 1/20th of the open surgery, if you consider the lowest level reported for spine fusion. And the reason for that is we don't produce that tissue. And it's important that even those 2 patients who got infected in our 1,400 group, none of them needed to be taken back to surgery.
Sure.
And because we don't create lots of dead tissue, dead cavity that the infection can spread. So those patients just healed with 5 days of antibiotic, oral antibiotic. So for all practical purpose, not a single take back to surgery. And if I show you some of those pictures of infection, and I'm going to ask Kayla to send you some, you see what a mess it is.
Right. Infections are
big deal.
Obviously, yeah, life-threatening. My mother-in-law, Kayla's grandma, actually got an infection, and she almost died from it. I was very close. Coma for many years, or many months. I'm sorry, weeks.
Yeah.
So
now, on top of that, obviously, after open surgery, because of the amount of recovery patient needs, average time of stay is 4 to 5 days. As a matter of fact, this is public knowledge, public information. You can go to CMS webpage and see which hospitals have to keep the patient how long.
Sure.
The average stay of the patient in the hospital, all hospitals in Minnesota is 3.2 days. In University of Minnesota and in Mayo is about 4 days. Our average hospital stay is 1.6 days.
Wow.
So,
and again, more chances to pick up an infection when you're in the hospital,
including COVID.
Right, exactly.
As well, we have to shut down the hospitals because we don't have enough staff or beds to take care of this patient. Now imagine spine surgeries need to keep the patient 1 day rather 4 days.
Right.
That opens up the beds for the people who need it for other problems as well, not only for spine problems.
How about scar length? That's important to some people.
Yeah, the scar length is very important, and Kayla will send you some pictures because there are multiple small incisions. They heal so well, and you practically sometimes have a hard time to see that. As a matter of fact, this has really happened that two of my patients went to a different hospital after my surgery, many months later after an accident, and they got x-rays and they showed it to the neurosurgeon in that local hospital. And the neurosurgeon told the ER doctor, are you sure this is the same patient? Because they looked at the patient's back, they looked at the films, they couldn't wrap their head around how that instrument got in. But I think more important than how big the incision in the scar and in the skin is what happened under the skin.
Right.
That make the surgery what it is.
Exactly. So it sounds like, and this is a problem very common with typical surgery or traditional surgery, is nerve root irritation, because you're going by that nerve root, and it sounds like the more times you go in, possibly the more irritated the nerve could get.
Mm-hmm.
So what is
I understand the question that what is the risks associated with OLLIF regarding the nerves, because you have to bypass the nerve.
Yeah.
This is your spine. This is spinal cord, and this is nerve root.
Mm-hmm.
In open surgery, we come from this direction. We push on the spinal cord and the nerve root to get in.
Gotcha.
As a matter of fact, there are reports and papers that about 8% of the time when you do that, you nick the spinal cord and the membrane around that. We call that risk of durotomy, 8%. And you have to push both. In our surgery, we go at this angle. We don't put spinal cord at the danger. So our risk of durotomy is 0, but we still have to put the nerve root to the side to get in.
Sure.
We tell our patient that risk is about 15%, but in truth, is much lower. But practically, we push the nerve root to the side to get in. And 85% of my patients, and we have 1,000 testimonials, patients wake up and they say, my leg pain is gone. What did you do? But 15% of the time, the nerve can get irritated. Vast majority of that is a new numbness. Like patients still go home next day, but they tell me that numbness on top of my left foot is worse, or I didn't have it before. It's okay, not bad, but what's going on? And the answer to that, we talked to them before, is that I have to push that nerve root away to get in. We did a systematic review of that. That risk as well is as high or higher with open old-fashioned surgery. But after open old-fashioned surgery, patients are so miserable, numbness on top of their left foot is the least of the problem. But if you ask them, they tell you that.
Right.
But our patients are ready to go home. That's the only problem they notice.
Sure.
But we consent them for that. And but obviously, like any other surgery, there are some risks involved with any surgery. We haven't figured out a procedure that is magic, but OLLIF is as close to magic as it comes.
Gotcha. So, I mean, do you typically give a steroid for that, or?
If the nerve irritation happens, we have a full protocol for that.
Gotcha.
That starts with some medication that cool the nerve down. Some actually physical therapy can be very helpful. with posture and things that doesn't aggravate the pressure
Sure.
on that nerve. But then we do steroid injection, meaning that we go to that nerve root, we deposit some steroid there. Sometimes as well, we give oral steroid, but the problem with oral steroid is that 95% of that goes everywhere else in your body.
Sure,
Only
sure.
5% of that goes to the place you want them to go.
Yeah.
But
yeah.
we have a full protocol for that we manage this because we have a lot of experience with this procedure. We have been able to put a good protocol to manage everything that goes with this procedure.
Gotcha. Well, that brings me to my next question. Actually, our recommendation always for any of our subscribers and people that follow us is like, if you're going to have a surgery, make sure the surgeon has done it at least 50 times. So, Dr. Abbasi, how many times have you done this surgery?
I have done this surgery 1,400 times, more than anybody else who has reported.
Wow,
but
that's crazy.
But that is just a minor thing I'm proud of. What I'm truly proud of is that I, with combination actually with my team, with Kayla, is part of that team. When you have done it so often, you know everything that goes with it. Right. You know everything that can go wrong with it.
Sure.
So we have put a curriculum together that everybody who join us, they get as good as I am in 1/3 to 1/4 of the number of the cases they need to do.
Right.
No different than when you are driving with your son. I'm sure your heart rate goes up.
Right.
You know all the mistakes he can do.
Yeah.
But you give them advice. You prevent them of having those bad results by pairing a good driver and a novice driver together. We call that process soft transition, where we pair experienced surgeon and surgeon who want to learn that to reduce that. And for the first time in the United States, I'm the person who, and my colleagues, we get our privilege in the hospital of other surgeon who wants to do that. I just came back from El Paso. We go there, we make sure they give the patient the post-learning curve result from day one. I just was in El Paso. We did 2 cases, both of them went home. And all I'm doing there, making sure that the surgery goes as safe as it can. There are very, very few examples of that the surgeon stop what he's doing and goes to somewhere else and make sure that this other surgeon does it the right way for the patient. And we have wrapped this process around what we call the Avicenna Technical University to truly teach it to whoever wants to learn it. Our take on that is this is beyond a surgeon doing something. This can change the entire care for the spine. Literally, patients who gather their pills to end their life because they are in such a pain, and other surgeons have told them, you cannot have that surgery because it's too invasive for you. We do an hour surgery, we send them home next day and we give them their life back. It would be unethical for us to keep the knowledge and sit on the process. So we are truly giving this process away to whoever wants to learn it.
That fits right along with our philosophy that we're trying to help as many people as we can. And you obviously are expanding that by helping other surgeons help as many people as they can. So it grows larger and larger. So again, that's ATU, that's your nonprofit university.
Correct. Avicenna Technical University. For people who don't know that, there are few people who really changed the course of human history. And Avicenna, or which is the Latinized name for Persian polymath physician Ibn Sina, practiced about 1,000 years ago, and he created significant medical and scientific methods about 600 years before Europe. And he invented many medical methods, and that is, in honor of him, we are calling the university Avicenna Technical University.
Oh, I love that. That's fantastic. I love that. We are running out of time here, so I wanted to be respectful of your time. So Dr. Abbasi, thank you so much. I'd love to have you on again, or anybody within your organization, if there's anything they want to talk about, we could do that. So
absolutely, my pleasure. I have made my life about teaching and public education.
I could see
and
that.
I'm happy to be back anytime. And I thank you for the opportunity to bring the message to the broader public.
The thanks all goes our way to you.